So thanks very much, Pete, and it's really a pleasure for me to be here. I'd like to also, on behalf of the university and the department, welcome everybody to this seminar. So one of the responsibilities that I have is I sit on the advisory panel for the FDA that reviews new devices as part of the device investigation exemptions in the FDA trials that need to be done prior to consideration for the FDA approval of these devices. So I've had the opportunity to sit on a number of these presentations, and so I thought it would be an interesting perspective since I have access to some of the data that you might not see that's published, and it's kind of interesting to see how this whole process works. This is a kind of an important area, as you'll see, going forward, and just in terms of the volume of it, and it's a little bit controversial. It's clearly technology that has driven this, and it's an interesting and exciting topic. But as you'll see, it's far from clear in terms of what is the better treatment, and for many of the reasons that have been discussed already this morning. So let's see if I can get this forward. So this doesn't occur in a vacuum, and the current treatment that artificial disc is being compared against is what our gold standard is, and that's the anterior cervical decompression or discectomy infusion. And it's a pretty good gold standard. I mean, it's an established, effective, reliable, predictable, and pretty durable procedure, very low morbidity, really not much in the way of any functional effects of single or even multiple level cervical fusions. It will correct and maintain your alignment, and it basically permanently immunizes the treated segment. Once it's fused, you really can't have disease at that segment, and for most, there's a fairly low reoperation rate. So it's a pretty good treatment that we have right now. Now, as you see that there's an increasing both in the rate and the percentage of cases that are being treated with anterior cervical fusion. So it's a large area. I mean, it's a huge market. These are routine procedures for most neurosurgeons and orthopedic surgeons. And it's estimated that there's as many as 50% of current fusions that are done, over 100,000 a year, would be substituted with artificial disc instead of fusion. There's a fairly easy insertion and revision of these fusions, unlike the lumbar artificial discs. Adjacent segment disease is perceived to be a problem in the neck, less so in the lower spine. And also there's some experience that you'll see that has come out of these cervical trials that was learned from the lumbar trials. And so it should be no surprise that there's a lot of competing discs out on the market. There's now 8 of them. I only put 5 right here, but there's a lot of them out there, and industry is trying to get to the market first, so to speak, have the best widget, and try to capture it while they can. And another, a little bit troubling for me, is that a lot of our peer review meetings and presentations are almost being used to market these implants. And this is just taken from 2 meetings over a period of 1 year. I mean, the number of presentation talks and posters on artificial disc replacement. I mean, it's a hot topic, and our science is really being saturated with these presentations. Here's another one from the Prestige cervical disc. So. And when you sit at these panel meetings, what they'll make the presentation industry will, and they'll say that there's a huge unmet clinical need that this new device is going to fill. And in the case of anterior cervical discectomy and fusion, that need is what's called adjacent segment disease. This is disease that will occur adjacent to, either above or below, where you've done a previous fusion. The idea is that you've created a lever arm, you've created a stiffness at a previously mobile segment, and you transfer stress from that level to the adjacent segment level, and that causes a lot of morbidity and the need for future surgery. And the scientific basis of this was kind of, I think, codified forever in these 2 classic papers. One that's very widely cited by Alan Hillenbrand, 1999, Journal of Bone and Joint Surgery, as well as a more recent one in 2004, where they looked at the long-term outcome at adjacent segments of patients who had undergone previous anterior cervical fusion. And so the Hillenbrand is probably the most widely cited, and they looked retrospectively at 374 patients who were treated with ACDF. You see that various levels were treated. 168 had 1 level, 132 had 2 levels, and then increasingly through that. And then they looked at the new onset of radiculopathy or myelopathy at an adjacent level, and they determined the incidence and prevalence of adjacent segment disease using a Kaplan-Meier life table method. And the average age was 51, and males equaled females in this study. And what they saw is that adjacent segment disease developed at a constant rate of nearly 3% per year. And they estimated that just over a quarter would have symptomatic adjacent segment disease by 10 years following their surgery. And about half of these patients with symptomatic adjacent segment disease would undergo and require repeat surgery. So this other study, this looked at patients who had undergone previous anterior cervical decompression for trauma and various reasons many years earlier. And what they reported, Goffin et al., was that 92% of their cases had adjacent segment disease at levels right next to either above or below a fusion, and that the severity of this degeneration corresponded with the time interval since the surgery, and the idea was that this was probably related to additional stress from the previous fusion. So there developed this narrative as kind of the scientific basis to meet the unmet clinical need for artificial cervical disc, cervical arthroplasty, and virtually every paper on this topic would start out with references to these two articles, Hillebrand here and then Goffin down here, basically quoting 2.9% per year, 90% incidence over 10 years, and you could just go paper through paper. And look, okay, here's Hillebrand here, and here's Goffin down here. So you couldn't get a paper published on this unless you put these names or these numbers in. So these were the classic articles. This was the narrative that developed, basically saying this is a big problem in the anterior cervical decompression and fusion. What was interesting, though, if you really read the paper and you analyzed it specifically, is that they came to a very different conclusion on their own data. Here's the Hillebrand paper, and just a quote, "Contrary to our hypothesis, the risk of symptomatic adjacent segment disease following multi-level arthrodesis was significantly lower than following single level." You would think that the longer your lever arm, the greater the probability of adjacent segment disease. They found just the opposite. In fact, 12% of patients who had multi-level fusions had adjacent segment disease, but the number was 50% increased by that for single-level disease. And actually a fairly small number of patients required surgery over a follow-up of 15 years, less than 10%. So maybe it's not such a big deal. And they actually, just to quote them, they ended their paper, "Therefore, we believe that symptomatic adjacent segment disease is the result of progressive cervical spondylosis at adjacent levels and is not caused by the arthrodesis itself." So they actually, I think, did a very responsible thing in looking at their data. And then if you analyze the data of the Goffin study, in a mean follow-up of a little over 8 years, only 6% of patients required repeat surgery. So it's actually a very low incidence in terms of the actual requirement for adjacent segment disease. And in this paper, the association between adjacent segment disease and clinical deterioration did not even reach statistical significance. So it's unclear whether or not these patients were symptomatic from the adjacent segment radiographic conditions. And then what's interesting is we're starting to getting some longer longitudinal data. This is by Goffin, who's a big proponent of the Bryant disc. And what he found, interestingly, was that they've had 4-year follow-up now in about 27 patients. 10 of the patients had no adjacent segment disease at the start of right after their first operation, and 17 patients already had some. And what it found is that if you didn't have adjacent segment disease at the time of your first surgery, you tended not to develop it when you had an artificial disc put in. But if you already had adjacent segment disease, which many of our patients do, it didn't appear that the arthroplasty helped prevent that at all. So it may be that it's this very narrow group here who may actually benefit from the cervical arthroplasty as you go forward. So anyway, let's look at the 3 trials that were presented before the panel that I sat on. This is the various devices right here. This is a stainless steel with Prestige. And again, it just has some screws that keep it attached to the spine. This is a Bryant disc right here. It's kind of a titanium shell and this polyurethane nucleus. And then down here you have this cobalt chrome, these 2 end plates, and then there's kind of a polyethylene plastic that clips into that. And so, they're very different, but functionality is fairly similar. And these are all prospective randomized trials approved by the FDA, and they've now all been published. These the lower 2 were published in 2009. The upper one was in 2007. Now, there's some unique aspects to the FDA trials. They're prospective, randomized, and non-blinded, but they set up in what's called a non-inferiority. In other words, you're not looking to see which one is better. You're basically saying, look, we have an existing device, a current gold standard, if you will, and we just want to make sure that the new device is substantially equivalent to it. We're not interested in superiority, we just want substantial equivalence. They do ask for validated outcome assessments more recently, and certainly in these trials they were used. And the overall success was really a composite of 4 individual measures. You had to have an improvement of your neck disability index of greater than 15 points. no neurologic worsening, device success not requiring any repeat operation, and absence of adverse events. And if you qualified in every one of these composite measures, you were considered an overall success. If you didn't, if you failed just one, then you were considered a failure. So this was kind of an interesting way to look at overall success that was approved by the FDA prior to the study. Now, the problem with that, though, is that it's one thing to get approved by the FDA. It's quite another to have it accepted by third-party insurers that they're going to pay for it, whether it be Medicare or private insurance. And what they do to determine their standard is a little bit higher than the FDA. They don't look for substantial equivalence. They look for a net health benefit. It's an either-or situation. It's a winner-take-all. It's either better than the previous technology or it's not. And if it's not proven better, then they're not going to cover it. And so that's a real problem for industry, is to say, look, you have two different standards. We've spent millions of dollars trying to establish equivalence as required by the FDA, and then these tech assessment panels are not going to approve it based on substantial equivalence. And so what's happened is, and this is a problem, is that they've pushed their data, I think, a little too far, and they've tried to make claims that were not really meant to be made based on the study design itself. They've petitioned the FDA. They ask us frequently, can we say we're superior rather than just equivalent? They interpret their own data. They put things in their papers, which I'll show you, which are not, kind of pushes the envelope a little bit. Again, trying to demonstrate that these are better, that there's a reason why you should use these new devices as opposed to the standard fusion. So they're in a rock and a hard spot with respect to the FDA data, because FDA approval is insufficient to demonstrate a net health benefit in general. The studies just weren't designed or powered to show those things. And so what you'll see is a lot of different publications and a lot of different presentations showing various benefits, whether they be cost, whether they be function, whether they be pain, and that's created a bit of a problem from my perspective, because I think that those are not really based on a rigorous review of their data. So I'm going to look predominantly at this study right here. This is the Prestige study, and there was a randomized prospective FDA IDE trial. There was 541 patients, and it was a one-to-one randomization. They had 2-year follow-up, a little bit higher loss to follow-up than we would have liked to have seen. And what they noticed is that they had a higher superior overall success with Prestige, superior neurologic success with the Prestige artificial disc, a lower rate of revision and supplemental fixation with the artificial disc, lower rate of adjacent segment disease and requiring reoperation, and a more rapid return to work with the Prestige disc. I mean, this looks like a home run. Statistically significant improvements in the Neck Disability Index, improved SF-36 scores, neck pain improvements favored the Prestige. And so they concluded that the Prestige maintained physiologic motion was associated with improved neurologic success, improved clinical outcomes, and a reduced rate of secondary surgeries compared to the ACDF. This was the paper that was published, peer-reviewed, did not have FDA approval to write to. We don't sign off on these papers. These are peer-reviewed in the journal. This was published in the Journal of Neurosurgery about almost 2 years ago. And similar results with the Bryan cervical disc arthroplasty, not as dramatic, published this year. And then here's the one from the ProDisc-C. Again, not as dramatic, but also favoring improved clinical outcomes, functional outcomes with the artificial disc as compared to the standard treatment. So there's some problems, though, and we have to go through those. So again, we're going to look predominantly in the Prestige study. Over 50% of the surgeons had a significant financial relationship with the study sponsor. Patient recruitment and advertisement from the study centers inferred that there was a superiority of the artificial disc over the standard care. Neither the patient nor the surgeon were blinded to the treatment, either preoperative or postoperatively, and the non-blinded surgeon was responsible to assess a number of the outcomes, such as neurologic status, device failure, and reoperation, and the return to work. And don't forget, most of these surgeons had significant financial relationships with industry sponsor. The other issues is that how they reported their surgical failures. There was no reporting or analysis of radiographic failures for the artificial disc. No adjustments here. This is some methodologic issues right here. But again, a lot of concerns with it. And it's hard to imagine how they would have claimed superiority when you look at neck pain versus arm pain are virtually identical when you compare the artificial disc to the fusion. Same thing here with the Neck Disability Index scores, and same here with the SF-36 scores for both physical as well as the mental. The other issue is that there's a concern over what we call a placebo or a nocebo effect, and that could create some participation bias. In other words, what patients actually agreed to randomization. So, the placebo and nocebo effect is, I think we all know, that it's a patient's response to treatment will correlate with their expectations about the value of a specific treatment. And so it was hypothesized that patients who desire or agree to participate in randomized trial had the perception of a superiority of the new treatment, of the investigational device, and that patients with doubts or negative perceptions of investigational device would refuse participation. So the deck was loaded before the patients even were entered into the trial. So that, so you'd have more patients than a random sample who would come in thinking that there was a superiority and were agreeing to participate in this trial because they thought it was a better treatment. And then the other is patient reporting bias. So one is participation bias, and then the reporting. And so patients knew which treatment they were receiving, so they weren't blinded. And the idea is they'd be pleased if they received the new treatment, the new and improved, the artificial disc, but disappointed if they received the old treatment, such as the ACDF, the so-called nocebo end of this. And so the subjective patient-reported outcomes, such as pain, SF-36, return to work, are significantly affected in both directions by a placebo or nocebo effect, as well as the greater or lesser intensity of the surgeon's care of this patient, because the surgeon knew which treatment they were getting. And so this was a concern. And here you can see where there was kind of a lot of advertisement going on. I went on some of the websites of the participating centers, and this is from UC Davis Medtronic. And this was actually during patient recruitment, which I found very curious and interesting. So here, Kathy's quality of life was down to 0, but she never gave up. Disc fusion was not an option in Kathy's life. The surgeons made the surgery look simple, even though it was not. This procedure is nothing short of a miracle. For more information about the study, contact the recruitment coordinator. So this is right on the website during patient recruitment. Here's another one, another center. After hearing how much faster and easier they expected my recovery to be with the artificial cervical disc, I definitely wanted to participate, and I have not regretted one moment from having this surgery. Again, contact the study coordinator. There's one down in Florida. Tracy Sullivan thought her severe neck pain and constant headaches were due to migraines. Fortunately for Tracy, she did not have to undergo traditional spinal cord fusion surgery, but instead had a breakthrough new trial surgery. This revolutionary new implant is called the Prestige. And thanks to her neurosurgery, Tracy is now back to her normal everyday activities and pain-free. So is there an issue here with placebo effect? Well, here's some data that you didn't see, which I did see from the FDA panel. If you looked at the patients who were randomized into one arm or the other and who refused participation once they figured out what the randomization was, there were 117 patients who were randomized but declined participation for various reasons. 34 patients withdrew because they were dissatisfied with randomization to the old treatment. No patients withdrew due to dissatisfaction with the randomization to Bryan cervical disc. So clearly this was a stacked deck in terms of the patient population. And interestingly, in this last study, they actually dealt with that by not telling patients what they were randomized to. And the differences between the two outcomes were decidedly different. In other words, there was no difference in the overall success between either treatment. The other problem with this trial was neurologic failure. And that, to me, that was a biologic plausibility issue. And you saw that patients who underwent the artificial disc did a little bit better in terms of their neurologic success. And patients who underwent the traditional therapy did worse. In other words, they developed new neurologic deficit. But they didn't develop it until 12 or 24 months after the surgery. And so I'm thinking, how does that happen? How do these patients do worse neurologically? No significant differences at 3 or 6 months, but highly significant differences, to use their terms, at 12 and 24 months. And to me, that's biologically not plausible. And so to me, that's a bias in data recording. And these were surgeons who had I think, a conflict of interest, and to me, that's a more compelling explanation of why we saw that. Particularly when you see here, and again, this was part of the FDA package, but not published. We see that there were much more patients in the Prestige group who had a deterioration in their arm pain following the surgery than in the control group who had the ACDF, and yet the neurologic success was dramatically different in the other direction. This just doesn't make any sense. Overall success here was better with the Prestige, as they claimed, but if you look at the reason for that is because there was a greater degree of surgical failures in the fusion group and a greater, double the amount of neurologic failures, worsened neurologic function following an ACDF. Again, these are surgeon recorded. Now, if you look at the control group and you try to compare this to your own practice, in the control group treated with ACDF, 2% required reoperation to adjust the implant position. I don't think I've ever done that. Pseudoarthrosis rate of about 3.5%, but almost all of them required reoperation. And I should say, it's pretty unusual that a pseudo for a single-level disc herniation requires repeat operation. And 5.5% will need another operation within 2 years for adjacent segment disease. I mean, this is almost unheard of in most practices for a single-level ACDF. And that greater than 15% of your patients are worse following a simple single-level ACDF. I mean, this is just not consistent with established literature, in my opinion. And if you look at the literature, this is a paper written by Mike Kaiser. Again, 96 fusion rate, 0 instrumentation failures, 100% neurologic success, and less than 1% adjacent segment surgery. And you can really go through all these large prospective trials and see that these kind of poor outcomes with a control study are just not present out there. So there's a real, a dichotomy in terms of what they presented and what our experience is. And the radiographic assessment, they didn't present. They presented to the FDA, but they didn't present of it. And 27% had less than 4 degrees of motion. That's the definition of fusion. So 1 in 4 patients didn't have any motion, really, following the placement of the artificial disc. They didn't even look at adjacent segment disease, even though they had it. So it seems to me that they probably didn't see any adjacent segment disease. And they said that that there might be some increased movement relative to the adjacent segments if you fuse the segment, and they really didn't see that in either the Prestige group or not. Again, this was not published data, but we could see it, that basically there was no difference between the two groups in the amount of angular and sagittal motion at the adjacent level following either treatment. So again, they've looked at some different economics. Impact of Prestige. This has been in the AANS meeting, as it's also been published in neurosurgery. Again, to try to identify some clinical benefit that will allow coverage of these devices. Interestingly, it costs more to put in a Prestige disc in terms of the implant, OR time, length of stay. But they said there was an earlier return with the Prestige, higher re-op rate with the ACDF, and so the treatment costs were higher, being out of work was higher, and so lo and behold, there was a net economic benefit. It actually costs less. So you'd save money putting the Prestige in. And again, the problem with that is that no standardized return to work criteria. There, obviously the cheerleader effect and the surgeon determining when the patient goes back to work. And physical activities and the use of an external brace were really at the discretion of the surgeon, and many more surgeons used a brace for patients who had fusion versus those who had the artificial disc. And clearly, if you have a brace, you can't drive a car. If you can't drive a car, you can't go to work. So there were kind of built-in biases to this, and so this is not a particularly valid conclusion. So this is just kind of the summary of that. Again, just a lot of problems in terms of the potential biases and non-comparability of these data between these two, the placebo effect, the possibility of bias on the part of the surgeons. So the question is it really safer, more effective, and cheaper? Is it truly better or just as good? And just as good in terms of third-party payers may not be good enough. And we just don't know whether it will provide enhanced clinical outcomes over time in the real world. And specifically what we don't know, will it decrease the incidence of adjacent segment disease? Only time is going to tell, but current studies are not definitive. And just to complete the story, I voted for approval of these devices for all 3 panels that I sat on because they are safe, they were effective, but they weren't better. Thank you.